Hello, my name is Imran, and I am Professor of Medicine and Endocrinology at Dalhousie University in Halifax, Nova Scotia. It is my honor and privilege to join you today through this video log, and I'm going to share with you my thoughts on an important topic, which is surgical indications for sellar masses. My learning objectives are as follows. At the end of this talk, we will understand and learn about common sellar masses and their surgical indications. We will hopefully recognize that most sellar masses can be followed safely without any surgical intervention. And I would also hopefully discuss with you briefly what are the preferred surgical management for different sellar masses. These are data from our own center that we gathered from our provincial registry through a population of approximately 1 million individuals. Sellar masses can be broadly divided into masses that are of pituitary origin and that which are of non-pituitary origin. Pituitary sellar masses include non-functioning pituitary tumors, prolactinomas, growth hormone-producing pituitary adenomas causing acromegaly, ACTH-producing pituitary adenomas causing Cushing's disease, and relatively rare entities such as gonadotropinomas, TSH-producing adenomas, hypophysitis, and then very rarely pituitary carcinomas and metastatic disease. Non-pituitary sellar masses, they are masses that arise outside the pituitary cells, and they include Rathke's cleft cyst, craniopharyngiomas, meningiomas, and rare entities such as chordomas, gliomas, cysts, and so on. In our own study, looking at the epidemiology of sellar masses, the most common entity was non-functioning pituitary adenomas. They accounted for approximately 39% of all sellar masses, followed very closely by prolactinomas, Rathke's cleft cysts, and then growth hormone secreting adenomas, craniopharyngiomas, and ACTH secreting adenomas, and then, of course, meningiomas and other rare entities. Let me tackle non-pituitary sellar masses first of all. The two commonest non-pituitary sellar masses are Rathke's cleft cyst, that account for 6 to 7% of sellar masses, and craniopharyngiomas, which account for 4 to 5% of sellar masses. In the slide that you can see on the left-hand side of the slide, there are two MRI scans showing cystic lesions, and these are images of craniopharyngioma. If you look at Rathke's cleft cyst, approximately 20% of these patients present with evidence of pituitary dysfunction, whereas in craniopharyngiomas, because of their location and certain other reasons, vast majority of patients, well over 70%, will present with some evidence of pituitary hormonal dysfunction. In terms of indications of surgery, the primary indication of surgery for these type of masses is vision loss. On the right side of this slide, you will see Goldman visual field test from one of my patients, and that clearly shows some evidence of vision loss. So if we see a patient with vision loss, that patient should undergo surgery. Number two, persistently enlarging lesion. And I think that is an important aspect that we should discuss. Rathke's cleft cysts, they tend to shrink and expand over time. And minor shrinkage and expansion we see from time to time. So in general, based on single observation of slight enlargement, unless there is evidence of vision loss, we do not recommend surgery. So relatively smaller Rathke's cleft cysts that show minor expansion, we tend to monitor them, follow them. And if there is evidence of persistent enlargement, then we would recommend surgery. I put a question mark with the third indication, that is headaches. Headache is very common in general population. Now, in some cases, without question, headache can be associated with pituitary tumors or sellar masses. But in our experience, most of these patients do not receive a lasting benefit from surgery. Some do. In most patients, headaches will come back a few years after removal of the tumor. So headache is a relatively soft indication for surgery in these individuals. How do we approach these patients, non-pituitary sellar masses? Both Rathke's cleft cysts and vast majority of craniopharyngiomas, they tend to be cystic. So in these cases, it is extremely important to make sure that you should seek opinion from an expert surgeon. The reason is that high rate of complications can occur if you attempt a total or subtotal resection of these tumors, particularly craniopharyngiomas. And that is because of the location of craniopharyngiomas in most patients. It can lead to hypothalamic obesity, which is a devastating consequence of injury to that area. There can be a loss of vision, neuropsychiatric dysfunction. There can be extensive hormonal loss. And that, of course, can lead to very poor quality of life. In our center, we very rarely attempt transfemoral surgery for these patients. We tend to use intracavitary irradiation, which is injecting yttrium into the cystic portion of the tumor. And what that does is it kills the lining of the cyst, and eventually over time, the cyst will tend to shrink. And that, in our experience, has been an effective treatment with relatively minimal morbidity as compared to transfemoral surgery, which can cause a lot of complications. What about non-functioning pituitary adenomas? Now we are coming to sellar masses of pituitary origin. Non-functioning pituitary adenomas, they account for approximately 40% of all sellar masses. And if you look at pituitary tumors or sellar masses that present incidentally, in those cases, more than half of these are non-functioning pituitary adenomas. Indications of surgery are very similar. That is vision loss, persistently enlarging lesion, and headaches. Again, headache is a relatively softer indication. I would like to add, though, that in patients who are unable to have surgery, for whatever reason, medical therapy may be considered. And the treatment options would include dopamine agonists such as cabergoline, and that, in our experience, has been effective in some patients. Somatostatin analogs have been tried with some success. And subsequently, there are other agents such as temozolomide, and these are typically used for very aggressive tumors, particularly if there is concern of a pituitary cancer. You can see this MRI on the left side of the slide, which shows a very large pituitary macroadenoma. And as you can see that it is pushing your nerves of vision, which sit above the tumor. And as a result, these tumors can lead to significant vision loss. What about functioning pituitary adenomas? In functioning pituitary adenomas, I'm going to obviously talk about prolactinomas, which account for most of the functioning pituitary adenomas, 30 to 35% of all Sellar masses, followed by growth hormone adenomas, ACTH adenomas, and exceedingly rare type of pituitary adenomas, which are gonadotropinomas and TSH producing adenomas. In case of growth hormone producing adenomas, ACTH producing adenomas, FSH and TSH producing adenomas, treatment of choice is surgery. Once we have made the diagnosis, these patients should undergo surgery for a remission. In certain individuals, if surgery is contraindicated or they refuse to have surgery, then medical therapy can be or should be considered, but the treatment of choice for lasting remission in these individuals is surgery. Furthermore, if the patient has a large tumor, which shows evidence of pressure effect on the surrounding structures, then clearly surgery is the first choice. If you look at the remission rate after surgery for growth hormone producing adenomas in smaller tumors, 80 to 90% of these tumors will undergo remission after surgery, whereas in larger tumors, particularly those that invade cavernous area, in those tumors, the rate of remission is significantly low, from 20 to 30% or even lower. With ACTH adenomas, because they are generally small tumors, and if you can find them and identify them, then the rate of remission can be as much as 60 to 80%, but the rate of recurrence is also quite high. Whereas in FSH, LH, and TSH adenomas, they tend to be relatively larger tumors, and rate of remission can be as much as 60 to 70%. For prolactinomas, and you can see on the image on the left side of the screen, this is a very large tumor, which is lobulated and infiltrating into the surrounding structure. Surgery is very rarely required in these tumors. Even if they're large, they tend to shrink quite successfully with medical therapy. The indications for surgery in this case would be if the patients have significant side effect to drugs like dopamine agonists, and these side effects can be nausea, vomiting, dizziness, nasal stuffiness, in some cases hypersexual behavior, and rarely increased risk of gambling. And in other cases, if tumors are resistant to medical therapy, and if you look at the tumors that eventually become resistant to medical therapy, these are typically large cystic tumors, more common in men, that is, men as a gender, if you like, or sex, and also in men 1, multiple endocrine neoplasia type 1, and also if you have very high prolactin at presentation. So if you have, so in males, in patients with men 1, patient who have cystic tumor, patient who have a large tumor, and if prolactin level is very high at presentation, then these patients eventually are more likely to develop drug resistance and may end up requiring surgery. I'm also going to talk very briefly about pituitary apoplexy, which is another indication for surgery in these tumors. Pituitary apoplexy is a clinical syndrome which is characterized by either headaches, vision loss, ocular nerve palsy, and of course, in some cases, hormonal loss. It can either be due to an infarction in the tumor or hemorrhage. Indications for surgery in this case you have to be very careful, because unless the patient has acute or worsening vision or patient is otherwise moribund, most patients can be followed conservatively, and they can be managed with hormonal replacement, pain medications, and otherwise the outcome tends to be reasonably good. But if there is evidence of vision loss or the patient is moribund, then surgery should be considered. And you can see on the left side of the screen large pituitary tumor with evidence of apoplexy, which is a big bright spot there. For those of you who have more interest in looking at neuroendocrinology and learn more about the pathophysiology of these tumors and how to manage these tumors, my colleague, Professor Michael Wilkinson, and I wrote a book which is available, and you're welcome to read it, and it should give you further information. Thank you very much.